It's very difficult to find out what would be the predisposing marker for these patients, but that would be one goal. Have a test where you can test the patient, say you are at very high risk, for this event. Maybe we should avoid, immunotherapy, or give you alternative, or watch you very closely. We are not there yet. What I actually started recommending, to my colleagues, and what I'm doing for patients who are on especially combination immunotherapy, when I tell the patients about these cases, make them aware to call with any malaise, any aches and pains, because it can be important. But I actually bring them back, especially initially, and especially on a combination every week, and check CKMB, troponin, CPK, EKG, just to basically see any early events. Of course, the problem could be that you will be finding some very small elevations of cardiac enzymes, which may make you act on that without actually, real reason for it. But the problem is, we need to, of course, do no harm. So I rather, find things early and maybe put more patients on steroids earlier, or maybe, just as a precaution, than miss, events like that. We also know that's another thing we know now, that patients who did develop side effects, toxicity on immunotherapies like checkpoint inhibitors, if you treated them appropriately with steroids, with a typical induction, steroid taper over 4 weeks, that actually their response rates, their chance for complete responses, their chance for partial responses and progression-free survival don't seem to be affected. So actually using steroids to suppress toxicity doesn't seem to be associated with decreasing the efficacy. So that gives me actually peace of mind that by treating patients well, I'm not harming them by lowering their chance of being cured.